Uh, Hello, doctors, for a new guideline video. Today, I want to read with you the cardiac arrhythmia guideline, which is very important in the MRCPCH exam. It's important in history and in video. It's important also in the communication as well. So let's read it together. As we all know that the types of arrhythmia divided according to the QRS rate and appearance of the QRS complex on the ECG. So we have the narrow QRS complex tachyarrhythmia, broad QRS complex tachyarrhythmia, and bradyarrhythmia. Okay, let's take it one by one. We have the NeuroComplex Tachyarrhythmia. We have sinus tachycardia. The rate can be more than 200 per minute, particularly in infants. However, rates of 220 to 300 per minute, most likely to be supraventricular tachycardia. So sinus tachycardia is it can present at a rate of more than 200 per minute, but you may get some cases with 220 up to 300. So this is going to be most likely SVT. Supraventricular tachycardia, the commonest tachyarrhythmia in infants and children, and this kind of arrhythmia comes up in the exam very often. And in your daily practice in a hospital, in the emergency room, you will face these cases on daily basis. Symptoms and signs. Episodes are usually recurrent and paroxysmal, rapid onset and offset. So it's recurrent episodes, paroxysmal, on and off. Presentation in infants. In infants, it would be in form of tachypnea, poor feeding, pallor, occasionally rapid onset of heart failure. In toddlers, episodes of breathlessness, pallor, cold sweats. In older children or teenagers, in form of palpitations, may be associated with dizziness or pallor. And how to diagnose this kind of arrhythmias? First of all, you have to do the 12-lead ECG with rhythm strip. So 12-lead ECG and with rhythm strip is crucial in here. If you have done the 12-lead ECG during SVT, you will find regular narrow complex tachycardia, rates between 240 plus minus 40 beat per minute. B wave is usually invisible. If visible B wave axis is abnormal and either precedes or follow QRS complex. Rarely regular, broad complex tachycardia if apparent pathway present. If in doubt, treat as ventricular tachycardia. Okay, so that's the first thing that we think about to do. It's 12-lead ECG with rhythm strip. When in sinus rhythm, Wolf Parkinson White, it will be very clear in sinus rhythm. Pre-excitation with short BR interval for age and delta wave in 10 to 20% of children. And the ECG in sinus rhythm could be normal and you won't see any abnormalities. Okay, what about other investigations? We need to do blood gas for acid-base balance, lactate, electrolytes, ionized calcium, very important. So that's blood gas for acid-base balance, lactate, electrolytes, ionized calcium, echo to assess structural anatomy and cardiac function. What's about the treatment? First of all, you have to think about resuscitation first. That's ABC approach. And you have to check the cardiopulmonary arrest guidelines for advanced pediatric life support. You will follow that protocol. You will continue cardiac monitoring with ECG, recording with each intervention you do. You may, after ABC approach, you may use the vagal maneuvers. We have different vagal maneuvers. We have what we call diving reflex, use of ice bag over forehead and nasal bridge for 30 seconds, or wrapping infant in a towel and immersing face in ice water for 5 seconds. So that's what we call a diving reflex, which is the same reflex that a diving man or a diving person, when he just jump or dive underneath the water. So he will got his heart rate slow, and that's the idea from where it come. So so again, the diving reflex, what does it mean? That use ice bag over the forehead and nasal bridge for 30 seconds, or whether you wrap the infant in a towel and immerse his face in iced water for 5 seconds. We have the other thing that we can do, the Valsalva maneuver, that's can be done in older children. They understand, and you explain for them what they should do. Or ask him to copy you, for example, blowing into a 50 ml syringe for 15 seconds while laying down. So that's one of the maneuvers can slow down the heart rate. Diving reflex and Valsalva maneuver. Note, not recommended ocular pressure for risk for injury. Carotid massage deemed ineffective in children. Gag reflex using NGT. So this stuff not recommended anymore. As long as it was recommended so far in the previous guidelines, in this new guideline, it's not recommended anymore. So this is what we call how to manage or how to treat the SVT. So don't attempt to do ocular pressure, no carotid massage, no gag reflex by NGT. Okay, the second step, the adenosine IV. Drug of choice, safe and effective in cases of SVT, ideally administered via large cannula inserted in antecubital foci. Administration need to be rapid to be effective, extremely short half-life, 10 to 15 seconds, must get into the heart as quickly as possible. So it's a rapid, quick injection of the adenosine. The half-life is between 10 and 15 seconds. It should be so quick delivered to the heart. Next page. Use a 3-way tab with lower lock syringes, 1 syringe for adenosine and 1 for sodium chloride, 0.9% flush. Never test cannula by aspirating blood into syringe with adenosine before injection. Will lead to breakdown of adenosine. Major route of elimination via active take-up by red blood cells and vascular endothelial cells where it is metabolized. Intraosseous administration of adenosine is ineffective due to time taken for venous return. Can be used in regular broad complex tachycardia of uncertain origin. If SVT resistant, SVT resistant to adenosine, seek advice from specialist pediatric cardiology center. And we have the note down there in the box. Do not use adenosine in irregular broad complex tachycardia, always seek advice from specialist pediatric cardiology center. Okay. So as we understand from this couple of lines in here that interosseous administration of adenosine is not effective due to the time taken in the venous return, and do not aspirate blood into the syringe before injecting the adenosine. This will cause breakdown of adenosine. If the maneuvers that you have done and adenosine IV not effective yet, so you have to seek advice from the specialist pediatric cardiology center for that. Okay, we have in here the diagram or the pathway for the management of SVT. It's like summarization of what we have read so far, and to put pieces together again. First of all, you have to assess if there is shock or not. If he is if he is in shock, you have to do vagal maneuvers. If no delay, yes. Establishing IV access quicker than obtaining defibrillator. So in case of shock, you will try the vagal maneuvers. If no delay in the preparation for the DC shock and the IV access. So if you don't have IV access, you will start the synchronous DC shock 1 joule per kg, and then you will repeat it over again, 2 joule per kg. After that, after two DC shocks, the first one is 1 joule per kg, the second one is 2 joule per kg. The third step, you have to consider amiodarone dose. After amiodarone, if there is no response, you will go back again for the DC shock 2 joule per kg again, and we will reassess again. Okay, if there is no shock in here, you will go straight ahead for vagal maneuvers and then for adenosine. If you establish IV access, you will give adenosine 100 microgram per kg, and then you will wait for 2 minutes. You assess the results. If there's improvement, that's good. If not, you will give another dose of adenosine, 200 microgram per kg, wait for 2 minutes, and if not effective, you will give a third dose of adenosine, 300 microgram per kg. And you have to consider adenosine 400 to 500 microgram per kg. In the neonates, 300 microgram per kg, maximum 12 milligram. You consider synchronous DC shock if there is no response, amiodarone, and other anti-arrhythmic medications. And you have to seek advice from the cardiology specialist as well. So that's the management of SVT, whether he has shock or not. So now we know the steps. It's very clear and nice in this diagram. In the books here saying do not use verapamil and amiodarone in the same patient, as both have negative inotropic effect. Do not use verapamil in children aged less than 1 year. So verapamil, it's calcium channel blocker. Do not use it in ages below 1 year, and do not use verapamil and amiodarone all together in the same patient. Okay, there's some talk and some explanations here about the DC shock. Synchronous DC shock, general anesthetic must be given if responsive to pain. Okay, subsequent management after what you have done after stabilization, you need to stay with the patient and follow up him thoroughly. So what are you gonna do? What's your next step? You will admit him to high dependency unit. continuous cardiac monitoring, of course, blood test to check for electrolyte abnormalities, urea and electrolytes, calcium and magnesium level. Discuss with specialist pediatric cardiology center. All patients will require pediatric cardiology follow-up, local or tertiary. So you have to involve the cardiology center anyway after admission, after stabilization. It's very crucial, and don't forget to do that. It's not your job as a registrar to manage all this by yourself. Once you stabilize the patient, you have to ask for advice from the cardiology center and the cardiology team as well. Okay, other uncommon NeuroComplex tachyarrhythmias. We have the, we can read it in brief. All of us, we know that. Other uncommon NeuroComplex tachyarrhythmias, we have ectopic atrial tachycardia, commonest cause of incessant tachycardia. B wave usually visible, but B wave axis usually abnormal, usually resistant to adenosine. So this is ectopic atrial tachycardia. Nodal or junctional ectopic tachycardias, usually in the early post-operative cardiac surgery period. Otherwise rare, B waves associated from dissociated from QRS. Atrial flutter and atrial fibrillation. Atrial flutter can be seen in fetal neonatal period at rate of 200 to 400 per minute. Sawtooth flutter waves on ECG with variable degree heart block. Adenosine resistant, but administration can help reveal flutter waves. Okay, atrial fibrillation, extremely rare in childhood, in teenagers with with Wolff-Parkinson-White syndrome, atrial fibrillation with fast conducting pathway can result in ventricular fibrillation and carries a risk of sudden death as well. Okay, so that's the supraventricular tachycardia and other tachycardias with small or narrow complex tachyarrhythmia. Now let's move to broad complex tachyarrhythmia. The causes of the broad complex tachyarrhythmias, we have the regular broad complex tachycardia and irregular. The regular broad complex tachycardias, whether it's unifocal ventricular tachycardia, 3 or more consecutive ventricular ectopic beats, sustained if continuous more than 30 seconds. SVT with apparent atrioventricular conduction. It could be associated with SVT as well. Irregular broad complex tachycardia. It's a multifocal ventricular tachycardia, long QT syndrome, Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia, which is stimulated by the high concentration of catecholamines in the circulation, like neuroblastoma, for example. Arrhythmogenic right ventricular dysplasia. Okay, atrial fibrillation with Wolff-Parkinson-White syndrome. So that's a regular broad complex tachycardia. It's going to be multifocal, for example, long QT syndrome, Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia, and arrhythmogenic right ventricular dysplasia, atrial fibrillation with Wolff-Parkinson-White. Underlying conditions which can be associated with broad complex tachycardia, it could be cardiomyopathy, myocarditis, post-cardiac surgery, known congenital heart disease, poisoning, for example, tricyclic antidepressant, quinidine, procainamide, phenothiazine, electrolyte disturbance, whether hyperkalemia or hypomagnesemia. So all of those may be associated with broad complex, a wide complex tachycardia. The diagnosis, it's going to be broad complex tachycardia, and it's going to be rare in childhood, differentiating between VT and SVT. With apparency can be challenging even for experienced cardiologists. How we can manage in this situation? Again, we have to follow the advanced pediatric life support protocol. If in doubt, treat as ventricular tachycardia. So in here again, we have in the next page the pathway, how we can manage the ventricular tachycardia. First, you have to assess and check whether there's pulse or not. If there's no pulse, that means he is shocked. So you have to follow the ventricular fibrillation protocol. If there is pulse, you can feel a pulse. Pulse present, yes, and he is shocked. Shock present, he is shocked. You have to go immediately to DC shock, 2 joule per kg. It's synchronized DC shock, of course. If fails to discharge, use asynchronous shock, DC shock 4 joule per kg. Next, you will use amiodarone, and you will reassess again. If there is no improvement, you will go back again and for 4 joule per kg DC shock again. Okay. Back to the diamond in here of the shock. If there is no shock, we have you can palpate a pulse, and there is no shock, you will give amiodarone 5 milligram per kg over 30 minutes, and consider the synchronous DC shock and seek advice, of course. So in VT or in ventricular tachycardia, if there's pulse palpable and he is shocked, you will go ahead for DC shock 2 and then 4 and then amiodarone. If there is pulse and he is not shocked, you will go immediately for amiodarone 5 milligram per kg over 30 minutes. You get the synchronized DC shock prepared by your side just in case. And you, of course, you will seek the advice from the cardiology center or the local cardiology team. Seek specialist advice early. Amiodarone may cause hypotension. Treat with volume expansion. So hand by hand, you give amiodarone and IV fluid as well, because amiodarone will slow the heart rate down together with hypotension. Use synchronous DC shock initially, as less likely to produce ventricular fibrillation. If synchronous shocks are ineffectual and child is profoundly hypotensive, subsequent shocks will have to be asynchronous. So keep this in mind. If you have started synchronized DC shock initially and it wasn't effective anymore with the child, and the child is shocked and hypotensive, and he is getting worse and worse, so the subsequent shock, it's going to be asynchronized. So what does it mean, synchronized and asynchronized? It's going to, you have to give the shock, apply the shock at the beginning of the QRS complex while you are checking the ACG monitor in front of you. Okay, Treatment of Dorsad's D points, ventricular tachycardia is a magnesium sulfate. So it's very, very, very crucial to understand and to know this piece of information, that if you have got a diagnosis of Dorsad's D points in a patient, which one of the types of ventricular tachycardia, you have to consider giving magnesium sulfate 25 to 50 milligram per kg IV, diluted to 100 milligram per ml sodium chloride 0.9% and infused over 10 to 15 minutes. So this is very, very good point to keep in mind. Because if you start the traditional treatment in this situation, the patient will not respond and you may lose your patient. You have to think about magnesium sulfate in this case. Okay, bradyarrhythmia. Incidental bradyarrhythmia in an otherwise well child may be normal and doesn't require any treatment. Seek senior advice. Okay, causes that require urgent management, pre-terminal sign in hypoxia or shock, raised intracranial pressure, vagal stimulation. That's the indication is need to that's indications requiring urgent management, pre-terminal sign in hypoxia or shock, raised intracranial pressure, vagal stimulation. All of these may cause bradyarrhythmia. Other causes: congenital complete heart block, long QT syndrome, conduction pathway damage post cardiac surgery. What's about the investigation in here? Of course, 12 lead ECG, 24-hour Holter monitor, check heart rate variability over 24-hour period, check for sinus pulses. This is very crucial in the investigations of bradyarrhythmia, bradycardia. 12 lead ECG, 24-hour Holter monitor to check the heart rate variability over 24-hour period, and to check for sinus pulses. The last page in this guideline talking about the management: treat only if child is in shock. So in bradyarrhythmia or in bradycardia, so you don't need to treat unless the patient in shock. So you will start ABC approach, ensure adequate oxygenation and ventilation, advanced pediatric life support pathway. If above ineffective, you have to think about adrenaline bolus, 10 microgram per kg IV, adrenaline infusion, 0.05 to 2 microgram per kg per minute, infusion, if bolus ineffective, if vagal stimulation is a cause, you have to think about giving atropine 20 microgram per kg IV or intraosseous, minimum 100 microgram, maximum 600 microgram. Can be repeated after 5 minutes. Contact specialist pediatric cardiology center for advice, and send 12 lead ECG. Okay, guys, we have finished the cardiac or the cardiac arrhythmia guideline from the Green Book for today. I hope you enjoyed it and you revise for your exam and you find this video is helpful. Please like and subscribe for this channel to continue uploading the new videos in the future. And thank you for watching.